So this is a very interesting time of the day after a complete day for a lot of interesting topics. And I want to reflect on a moment on the council meeting we had, which started on Sunday and lasted until Monday, with the council members from the National Academy of Medicine and Victor Chow, the president. And we're talking about, he was talking about reflections, he was talking about culture, innovation, things that are important for the Academy, going forward now that we're looking to see what should the Academy look like over the next decade. And the fact that there's going to be a 50th anniversary, I think, of the IOM coming up very shortly. And Victor was saying that one of the signal reports that really led to the whole quality issue, performance improvement, was to err is human. And he said, at this point, we should begin to thinking that to care is human. So if we think of that in terms of what we've been talking about all day long, I think that's a very prudent point. To care is human. And that's exactly what we're trying to accomplish. So I think we should remember that for the rest of our time. To care is human. Okay, this is a nice time of the day when we'll give each individual an opportunity to reflect on some of the issues that were heard during the day. Just one or two. We have at least 20 some odd people we want to go through. And they're very important because, as I said at the beginning of the day, we do reflect on those later on, and they do give us ideas as to what next steps should be based upon your impression of the day. So let me start with Michael Wolf, and we'll go down the row from there and then around back to Anne Louise.
So England is losing to Croatia. This is not a good sign.
2-1. What's the score, Mike?
2-1. 2-1. So let's not. So I think the conversation for today was really interesting. I really appreciated a lot of the fact. There's a lot of similarities in terms of how you. I would say the major comment for me is all this comes back to assessment, whether it's about behavioral or mental health issues and what gets missed. I think the very first step in issues around cognition that we talked about, I feel like a lot of this just gets me thinking about how much we really don't know and are prepared to, how much we really don't know about patients, which we've learned quite a bit about over decades with health literacy, and how much it is doing detriment to patients until we can do a better job of capturing the whole patient and their experience. So I think even before we get to payment models and restructuring and big futurist stuff for our healthcare system, I feel like we have to at least start to understand the full extent of the barriers that patients face as they engage in healthcare.
Michael, you have another word that you want to add to the vocabulary?
Well, I think without sitting back, without thinking about this issue of dualism, without thinking about that, and without thinking about why we put the patient, the doctors in the middle of the circle, I think there's really no chance. And so many people haven't challenged their basic assumption that there's this mind and that there's a body. And if you can sit that down and look at that, you can say, okay, I'm going to commit this system, I'm going to commit this care, I'm going to commit this clinic, I'm going to commit my learning to humanism, to this person sitting in front of me. And that's just a different approach.
To care is human. Steve?
Yeah, I thought today was really wonderful. I'd like to thank the staff for all the work that they did to pull it together. What stood out for me today was an extension of our November session where we talked about the business case for health literacy. And as I go along and as we go along for culture change within organizations, we have to make various arguments. In November, we saw the business case, we saw handle time for calls, a lot of money. Today, focused on why do we have to think about health literacy? Is there a difference the way people receive information, process information, and communicate information based upon mental health, mental illness, behavioral issues, what impacts those things are. And I think as I'm preparing to do some training for clinicians, today's presentation really gave me a lot of ammunition to talk about, yeah, there's a dollars and cents, but here's why. And here's what I think you may want to think about as you are approaching people to reach out to them, to care, to show that you care, and to make care human.
Ellen?
Well, one thought I had now that I hadn't realized before listening. So one thought that I had hearing this final discussion, is that better? Yeah. Is a few years ago I was on the NAS work for workshop on considering the child care workforce from birth to age 5. And I was struck by the conversation now about how some of the recommendations are really identical to what came out of that, actually volume that is now, has been published for a few years. But much of it was that the need to integrate lots of different kinds of professional expertise and people in systems where you can have teachers and pediatricians and parents kind of collaborating and working together on understanding what is happening rather than different pockets of expertise that aren't communicating with each other. Anyway, I thought that might be of interest to look at what those recommendations were, because it really sounds really resonated. One other quick point is, in terms of the issues about overcoming stigma and bias, there's many domains where these issues are coming up now. Probably all of you are familiar with. In psychology, there's a kind of influential field on implicit bias, where it's coming into play now. For example, at Stanford now, when people are conducting searches, there's issues about how can you alert search committees and faculty to implicit bias, because you read resumes of people differently than if they're depending on their gender or depending on their race. How to alert people to what their implicit biases are and how to overcome them, or try to be aware of them when you're evaluating information. And there's this is also coming up in issues certain that was alluded to earlier today, sort of about kind of implicit bias among police, where you're faster to see danger or a weapon if it's an African American man than if it's a white woman, and who's more likely to be shot. So it seems as if there's from different fields, growing expertise in how, or growing concern, and maybe some consolidation and collaboration on that kind of expertise could end up being useful as well.
Larry?
I was struck at how much we talked about communication for the whole first half of today's session, and realized that, health literacy is all about bringing the patients to a point where they can participate in their care, but participating in your care is more work. It requires unbelievable trust in the system that's asking you to be the active participant in that care. And without communication, you'll never build the trust. Without trust, no one, even if they understand their illness, will ever go along with the things you're just telling them to do. And behavioral health issues in the patient you're communicating with adds a new layer of complexity to what are the effective strategies in those encounters that build trust. And I think that's one of the things I have to go home now and think about, because I think it's a complex issue of that building of that trusting relationship.
We have a whole meeting coming up at the end of July on trust. Vanessa?
So actually, that's also what my comment was about, was this thought of just that trust and respect is important to all of us when we go to the medical encounter, but especially for communities and people that look different than the people that are providing the health care. And that's even more kind of emphasized today for those people experiencing the stigma associated with behavioral health or substance use disorders. And so I was thinking this morning about, what is that competency providers are supposed to have that can increase trust or make them be more respectful? And I was struck by a comment about it takes a special kind of provider or person to be able to do this. But really, I think someone over here said it shouldn't be that going that extra mile should be the expectation, not just that they're actually going an extra mile. But like Dr. Smith was saying, I think my head is it is a complex issue, and I think it does. I'm glad you're having another meeting about it to think about how do we do this, how do we change systems, how do we help providers have those skills.
The ABAM, what I was referring to, the ABAM Foundation has their annual forum coming up. 3-day meeting is just on the issue of trust. Cindy.
And please bear in mind that I'm also saying what I would say tomorrow morning were I there. So I wanted to start out with universal precautions, which is where Bernie started us this morning. And I thought that was really brought home in our very first speaker when Lisa talked about her husband. And the idea of universal precautions is not, I'm looking at Mike, that we treat everyone the same. It's that we treat everyone as if they are at risk. And so it seems to me that universal precautions, real health literacy mantra, really connects very well with behavioral health. I also, though, heard Lisa talk about the fear of hospitalization, and that is very real. And so it made me think about how we need to alter our shared decision-making models from what we have in a medical setting, and also recognizing that the patient and the caregiver's interests are not always aligned, that sometimes family members want things for the person they're caring for that the person doesn't want themselves, and so that adds a layer of complexity. I also want to point out that part of health literacy is making it easier for patients to navigate settings and systems, and so the integration piece is really central here. And now I have to earn my salary with an infomercial because ARC has an academy for integration in behavioral health and primary care, and there are resources there. So I urge everyone to take a look at that. And my second infomercial, because Michael Pashorlo mentioned about the team care that several times, and there is, in addition to the regular Team Steps modules for office practices and hospitals, there's actually one about limited English proficiency and including the interpreter in the team and creating psychological safety for that person to say, excuse me, step out of the interpreting role and say, excuse me, but I don't think they understood. So I'm getting close. I wanted to raise open notes because that hasn't been mentioned, and we heard about somebody's notes being written that they denied depression, and I've actually had personal experience where I was denied disability insurance based on somebody writing a similar thing and having to fight that. And I think that the one change that I've heard reported about how doctors or clinicians are scribing when there are open notes, which means that the medical notes are open for the patient to be able to peruse, is around substance use disorder. So that is another health literacy strategy that might help change the language of the discourse that speakers noted was very important. And finally, getting to Michael Pash-Orlow's does it pay the rent question. I think that what we heard from Brandon was so terribly important because it did show cost savings. And so Michael said that there are lots of studies showing that this is beneficial. And so one thing that the roundtable might want to think about is commissioning a paper that kind of marshals that evidence around collaborative care and the cost benefit and how we might push that forward.
Thank you. Gail?
Thank you. This was my first meeting. It was fascinating, and I learned a lot. So thank you to everyone. The things that are in my mind remain sort of questions that were sort of raised during the course of the day, and they just remain questions in my mind. I certainly don't have any sort of answers at all. One of them related to the gap. I think this is Larry's comment, gap between training clinicians, training people ideally, and then they get out in the real world and they can't follow through with the things they know. And whether that's a new clinician coming out into the world or someone maybe who's already been practicing and knows they need to do it better and is taking continuing education, really identifying what are the things that get in the way. Is it the clinician's entrenchment with what they're doing? Is it the lack of time? Is it there's not a payer for the amount of time? I don't know what those elements are. I'm sure there are a lot of them, and I'm sure they're complex. But that goes on across the spectrum of healthcare. It's not, so I'm in dentistry, right? And we see that in dentistry. So I think that's a problem that needs to get solved. Why do we know what we should do, but we can't implement it as individual clinicians? So that's one of the things that's in my mind, that gap between having the training and then the real world, whatever that gap is. The other thing in Brandon's, I just really enjoyed that presentation, and it made me think a lot of the discussion today was about how clinicians can do a better job with their patients, be more effective with their patients. But we have the larger issues around just the population improving, and there are so many people, probably more than that don't walk through the door than those that do walk through the door. And that's where law enforcement comes in, right? So that's when they haven't walked through the door, but something else has gone bad. And another part of the system is trying to respond to that. So what else can we do? The type of programs like MedStar, what else can we do for those that the clinicians are never going to touch? Unless some other change occurs. So those are some of the things that were in my mind. Thank you.
Johanna?
So this was also my first meeting and an amazing experience. So thank you. I think that I echo a lot of the things that were said already, but I think that although I acknowledge that we need very intellectual folks to fix all of these big systems, things that need to be fixed, I was a little bit blown away or reminded about that even the very simple things can actually lead to big changes. And I was reminded of the power of words and how just simple words can actually create bad outcomes, good outcomes, fear, trust, access, all of these things. And simple examples today, so, using things like committed suicide versus died by suicide, or substance use disorder versus substance abuse. And again, just reminded me of how I always think about these very complex, technical, adaptive challenges that need to come to sort of fix the things, but sometimes also just the very pragmatic, small, simple things can actually lead to better outcomes for most people as well.
Good point. Winston?
Good afternoon, everybody. And as some of you know, I also sit on the Roundtable for Health Equity, and we met about 6 weeks ago in Philadelphia around the impact of incarceration and reentry into communities on issues of health equity. And we couldn't help but discuss the issues with regards to de facto, our so-called criminal justice system has become a mental health delivery system. And as Michael had pointed out, a poor substitution for a mental health delivery system. So I just wanted to highlight that as one point with regards to looking at the intersection around these issues, particularly as it applies to equity and communities of color and tribal communities, and that in fact we are reproducing a kind of intergenerational aspect of how mental health is criminalized basically within our society, and we're never going to make any progress until we address the issues that overlap between health literacy, access to care, and racism and class issues. So that's one point. The other point that I want to make, and it's a bit more optimistic, I think there's a precedent for how we look at health literacy to something as profound as addressing mental health. And I think that has to do with the great leaps that we've done around HIV and AIDS prevention. And if you take away the lessons from that, I think we need to take this and internalize it for our issues around health literacy and mental health. One was identified as a global issue. This is not just a specific American issue. The issues with regards to how different cultures across the country look and understand mental health and substance use disorders is an important aspect. Secondly, I think public health, this is a public health issue. It's not just an individual clinician and patient issue. It has to be elevated to how does a community, how does a neighborhood, and how does a region and a state deal with the issues of trying to demystify the issues around mental health and to indeed destigmatize it. The third aspect I think we can draw from HIV and AIDS is that the work was not done specifically around clinical leaders. The work was done around leaders from the community that agitated, that identified who was at risk, and to make those issues. And sometimes they were overly agitational, let's say. But I think because that happened, I think if you look at where we are in talking about HIV, which is a very complex disease, retrovirals, et cetera, viral load, I think our general public is starting to understand and destigmatize what it means to be at risk for HIV, namely all of us, and how you think about prevention and treatment in the long range. So I think there's some important lessons to extract from that experience. We have still a long ways to go with regards to HIV and AIDS, but I have to say 30 years ago, it looked a lot less depressing than it does now.
So your point that this is a public health issue is a real good point. In addition, surrounding that, I do believe is the social determinants of health. So if you put those two together, we really have a theme. Terry.
I was just struck again by how much we need to improve our healthcare system to make it easier for patients, more useful, and that when we discharge patients, they still need support at home. And we sometimes forget that, especially in the hospital, they're not well when we discharge them and they need help. And I don't know anybody who thinks it's easy if they've been a patient who says, oh, I had the greatest experience or an easy experience. But people say that a lot about their vet. They feel they can get in, the instructions are clear, the vet cares for their dog or cat, and so they're doing a pretty good job. I will say I do think over and over again, communication, trust, relationship, everybody wants to feel that their doctor cares about them and their situation. And the good news is, as a faculty member, longtime faculty member in medicine, the gold humanism is just taking hold at our medical school. The students are embracing it and seem to value humanism in medicine more than I have seen in medical students since I've been there. There's a real value for humanism in medicine. At least they're talking about it.
I hope there always was.
I think there was, but it's like now you get...
I shouldn't say was. I hope there always is.
You get these stars for being, the humanism student of the week or something.
Gotcha. Michael.
So I really enjoyed the presentation today. I was really just very educational, enlightening for me. I think the things that really I wanted to emphasize and agree with are the need for this collaborative environment, but also emphasizing the importance of not only the social workers, nurses, and also even interpreters, but going a little bit further to make sure even patient navigators, community brokers. So we need to get the community members to be part of it because while I agree diversifying the workforce is critical, and it's very important to do, and I'm hoping will happen. But there's still going to be an element where we're so different from those patients. A lot of our patients, whether it's educational differences or income differences. So without having them there, and we really need to think about a sustainable way to have them be included. So I really want to make sure that we incorporate that mentality as well. The other thing I wanted to just maybe highlight, my growing concern is that I really do feel we're kind of returning to even more of a fragmented healthcare system. So while we're talking about where we would like to go, we also need to protect some of our gains. And so with the further fragmentation, I'm worried that we're going to reverse a lot of the hopeful improvements that we're expecting to get. It's also will be exacerbating a lot of the haves and have-nots. And even back home where I'm coming from, there's proposed concierge models which emphasize a lot of what we're talking about: longer visits, personalized medicine, ability to have multiple communication channels with providers. A lot of the things that we really are talking about, we need to do for everyone, but it takes $4,000 to enroll in this program. So, it's this shift of this elitist model, and we need to just be on guard and really figure out ways we can protect those who don't have those resources. The other thing is, there's been a shift in medical school education. I really do feel that there's still a lot of room for improvement on not only knowing how to take care of our diverse patient panel, but even just talking about how to communicate basic principles. I mean, we heard things like the laptop was in front of us, this reliance on electronic health records, and just not really knowing how to communicate. Well, it's taught, it could be taught better. And also even teaching how to engage certain types of patients. Sometimes we put a lot of work on looking at very rare conditions when the bigger, more common, more prevalent conditions are not well addressed. So I think those are some of the points that I just want to highlight. Thank you.
I also want to thank the two interpreters for their assistance today. And later. Lori?
So I knew coming into today that depression was a barrier to medication adherence. But I think today really enforced that medication is an important part of managing both mental health and the general health of people with behavioral health challenges. So for me, in my role, it really reinforces the need for pharma companies to continue to think about simplified dosing and clear information about medicine and disease to reduce the cognitive burden. And I really think we have a role to play there. And I want to be like Cindy and channel Rima. And, I really do think that education is a tool to address the stigma associated with mental health. My daughter, when she was in 8th grade, had to do a family tree, and they asked about health. And not only who is it, but what health conditions did they have for her health class. And I think, you could do an exercise like that with mental health, right? And start to have a dialogue with children, in much the same way that, there's transgendered bathrooms in middle school now, right? That's an example of how something that 20 years ago wasn't talked about, that we could make part of the conversation. And then also education in medical schools, other healthcare providers, as Winston said, of community leaders. So I really do view education as an important tool to address stigma.
Thank you. Chris?
Hi, Chris Desi, RN, MBA, humanist. The things I'm going to bring in tomorrow's talk are that stigma is and others, among others, stigma is a significant barrier to health literacy and/or the deconstruction of dualism. We'll talk about that tomorrow. And also that cognitive screening is personalized and/or precision medicine. All right, that's all I have to say about that.
Ernestine.
Ernestine Willis, Medical College of Wisconsin. But I want to repeat some of the comments that have gone on earlier about communication. I think I I guess I want to reinforce interpersonal, bidirectional communication is foundational to building trust as well as empathy, especially for populations who we need to work on getting to health equity. The other concern, and I guess I did hear the collaborative care, which I applaud, but I wondered, and team care, but I wondered, are we still staying in a small bubble, that we're not thinking strong and broad enough outside of the bubble? I go back and reflect on the social determinants of health, and many of you who've read the book by Matthew Desmond, when we talk about what's going on in Milwaukee with evictions and what is happening with many of the population. There's so many players that affect the whole health of a population that we may need to always think that we're talking broader collaborative if we want to address health disparities. And it goes with your point about social determinants of health. The last but not least I wanted to just bring up, and I'll bring it up tomorrow too, is that what we see and we experiencing in our society around school violence, gunshots, I think many of those cases have some mental issue, behavior issue with it, and I'm hoping that it's a symptom of health, behavior health as well as mental health that we may want to at least talk about at some point.
Jennifer?
Well, Winston's comments helped me put together some of my thoughts. I remember when I trained in infectious diseases, there was a study that came out that looked at medication adherence, and one study showed that the distinguishing factor in the adherence was whether or not the patient perceived that the people in the clinic cared about them. And it occurred to me that, using health literate practices is a good vehicle for communicating that respect. So it's kind of puzzling to me how we in the health system have spent so much time training doctors, and I was a recipient of that training, at how to talk to other doctors and so little time about how to talk to patients. So you end up with miscommunication. So is a positive test result good or bad? If it's positive HIV test, that's a good thing, right? No. And the same thing with denial. So the patient denies abdominal pain or that means the patient said they didn't have it. But what people hear is the patient has it but won't admit it. And so we have all those little cliche trick things that we somehow can't get beyond that, so that we communicate well and with respect, and we tolerate behavior from patients, from physicians toward patients that, really should never be tolerated. But we don't have a good way, and I think, of correcting it unless we go to the quality improvement route. And then it becomes a quality improvement issue that's measurable and disciplinary for staff and patients that treat people with disrespect. It's a very tough issue to deal with, but I'm not sure positive encouragement is going to get us where we need to go. We may need stronger disciplinary action so that overt disrespect is just not tolerated. So that's all I have to say.
That's Oleanka.
So I had a couple of thoughts about today's presentations, which were all great. The first one I wanted to mention is one of the things that resonated with me is the support and advocacy for not just the patient. We've been talking a lot about the patient, but also the caregiver, because I think we started that conversation in March talking about caregivers and for older adults. And today I was fascinated about the fact that we also need to think about the family member and think about the resources that they need and the information that they need. And it's not just building the trust of the patient with the clinician, but also building the trust of the family member or the caregiver with the clinician. and be able to provide support and resources to them. So I saw that as a little bit of a carryover of those caregiver conversations that we had from last March. The other thing I wondered about is, and I didn't hear a lot of discussion about it, is access issues. You know, I looked at the presentation by Dr. Park about the online communities, and we see that a lot of people are going to social media, and patients who are depressed or have anxiety are using that communication channel to be able to talk about some of their concerns and seek out health information. And these are individuals who probably have not even seen the clinician to even be able to start that conversation or even talk about even developing a trust relationship. And so what happens to those individuals within that space? And how do we go to such an untapped place to be able to get to those individuals?
That's a very important point. Very common, by the way, in the autism community, in addition to the use of social media, because the inability to communicate sometimes forces the person to go to social media. And whether that's a positive or a negative, that's what you're raising. Yep. Katina.
I don't know that I have much new to say, but I want to say again how much it matters when we start our day with people who are living experiences and they help guide us. And I particularly appreciate that several of those folks stayed throughout the day and gave us their whole day. I think it holds us accountable to communities. It's very nice when people come in and speak, but they don't always listen to what we have to say, and it changes the tone of the conversation. To know that people are in the room and they're asking questions and they're online tweeting, and this is not a us or they, it is we are all actively having a conversation, and we have to pay attention to that. So Lisa's still in the room. Thank you. Thank you for staying all day. I think Kate was here until just a couple minutes ago, and it's a big deal to give a whole day of your life. So and sort of expose yourself in that way. So I think it's a big deal when the roundtable spends the time to get people who can do that and speak their truth bravely, and then also stay here to be part of the conversation. So that's the first thing. And then the second thing is, my number one agenda in health literacy is that health literacy is not a silo, and we certainly have to own the language that something real is here in health literacy, but the way that we make this work and sort of succeed is to push it out beyond our little space. And I think we did a really great job of that today in a conversation, and I would encourage us to think about what interventions we might embrace as our own, so that we could perhaps make our little stable a little bigger than just teach back and plain language and some of the other things that we are very comfortable using. Seems like there's good evidence that motivational interviewing, for example, has components, all the components that we would embrace in health literacy. So I don't know why we're not sort of saying this is an intervention that has the characteristics of a health literate best evidence intervention, and this is what we use. And I don't hear people do that, so I'm pretty excited about that. And same for these, whatever you call collaborative care models. I think there's lots of language, but we should be talking about that really clearly, that there's a path, and it's not a guessing game. And just because we didn't create it doesn't mean we can't use it.
Thank you. Jem?
So I have been thinking all day about something that I think Helen Osborne eventually said, and that is how we get this innovation out into the world. And when we talk about collaborating, I'm thinking about collaborating with nonprofit organizations, community-based organizations, community health workers. I worked for many years in community-based nonprofit organizations, including in the early days of the AIDS epidemic. And there were many, I think of many situations where I think we could have used some of these tools, and oftentimes these organizations are the first contact for folks, and unfortunately sometimes the only contact they have with health information. And so I'm hoping that should be a part of our collaboration and the world that this information is getting to. So thanks.
And Anne-Louise.
Thank you. I wanted to thank all of the speakers and discussants. I come into these meetings thinking I already know so much and there might not be anything new, and I leave thinking, oh my gosh, there's so much I don't know.
Isn't that nice?
It's wonderful to keep learning like that. So thank you to everyone. I found it interesting that our workshop title is the intersection of behavioral health, mental health, and health literacy. And to caution, I would remind us all that we know what happens on a busy street and a busy intersection, or what can happen sometimes. There can be collisions. And I think that it's important that we make sure that we fully understand, with extensive input from both patients and the community, what exactly the needs and the wants are of the people that we're trying to help before we jump in from our ivory tower and try to tell them what they want and fix things. And I think when you're talking about people who have issues with health literacy or who have issues with mental health, that's even more important, because it might take a while for them to get across to you what they need, but they do know what they want and what they need. So it's important that we involve them in that process. And I think what's also important is that when we use words like mental health or behavioral health or even health literacy, we need to make sure that all of the stakeholders are understanding what those words mean and we're using them all in the same way, because we can be talking about possible solutions, but if we're not understanding what the issue is, then we can't really ever address that fully or properly. So that's what I'd have to say.
Well, thank you all. Those reflections will be very helpful. Before we end, Lila and Melissa and Alexis, I want to thank you all for the work that you've done to put this together. And hearing and seeing no other comments to be made, thank you all very much once again. What was that? 6:30 working dinner, and we'll see you then.